Hello, this is Emily Peters, recording for Nursing Care of the Growing Family, Unit 5, Lecture 4 on structural defects. So we have several common structural defects that you will see, or you could see in that newborn stage of right after birth. So one of the structural defects that we need to be assessing for after a baby is born is cleft lip and cleft palate. These happen somewhat early in the development of that baby. The cleft lip and cleft palate can occur together or separately. It's a facial malformation that involves the lip and the palate, or one or the other, or both. The lip occurs because of a failure of the maxillary and medium nasal processes to fuse. The palate occurs when there's a midline fissure between the palates, and that doesn't close. So you have a failure of that fissure closing, and so the two sides don't connect. With the palate, we have more concerns related to feeding. It can affect the dentation or the teeth of a child. It can affect language development and hearing. There is some belief that these are inherited. They can occur with other syndromes or exposure to tetragens while the mom is pregnant. Various things. The only way to fix these is to do surgical treatment. The cleft lip will do surgery first. If they can, they'll do it around the 6 to 12 week, between 6 and 12 weeks of life. The cleft palate, they'll do around a year to a year and a half. And this is all going to depend on the baby's health and growth and development. We need to get these fixed fairly early on so that we don't have long-term issues related to that cleft lip and cleft palate. So this is an example of a cleft lip. This is a what I would consider a unilateral cleft lip. You can have bilateral cleft lips where you have two clefts. I believe we may have a picture of that as well. This little guy, from what I understand, does not have a cleft palate. And you can see that with just a simple closure of it, he just has a little bit of a scar right here. And it is very relatively unnoticeable as that kiddo grows. Here's another example of a cleft lip, and this is a bilateral cleft lip. So you can see how with the bilateral cleft lip, the kiddo has the two openings. And then they just kind of put it together, and it's a little bit more severe of a scar. This scar tissue and things like that can be fixed with plastic surgery, and at times you don't even see much of that repair that is going on. So nursing care of the cleft lip, cleft palate. One thing that's going on is, especially when you have a cleft palate, they're doing it later on as we are having a lot of that structural growth going on. And they end up doing a plastic plate guard to form that plate that never developed in that baby. And that helps allow for introduction of solids and help preventing that aspiration and things that are going on. Some risk factors related to getting a cleft lip, cleft palate, besides what I mentioned, like Dilantin use, alcohol, that low folic acid, Accutane, smoking, different things along those lines as well. With a cleft lip and cleft palate, some of these kiddos cannot breastfeed, and therefore we end up needing to do bottle feeding. Now, we have aspiration issues. We have an inability for these kiddos to do a good complete seal around the nipple of the breast or even around a bottle. And therefore, that increases the issues with nutrition. So we got to remember a big issue with these guys pre-surgical is nutrition. Okay, that's a huge hierarchy of need, and that nutrition can be either breast or bottle. Breast sometimes is easier if they are able to breastfeed because that seal is a little bit easier to occur because of the breast and how it falls over the mouth. However, we have special feeding devices and nipples that we can use that help with the flow. So, for instance, like if you've ever seen a regular bottle, the baby has to have a lot of strength and suction to pull the milk from the bottle. Well, with these cleft lip and cleft palate kiddos, we use nipples that have a little bit bigger holes in them so that the milk flows a little bit easier. But we also, some of these bottles have like a softer plastic to it that when that baby is sucking, whoever is feeding them just applies just a slight amount of pressure on that bottle to help that milk to flow. Also, when we're doing this, we limit their feeding sessions to avoid overuse of calories, and also fatigue from eating a lot. We also want to maintain a little bit more of an upright positioning because they're at high risk for aspiration. So there's a few things that we will need to do to help these kiddos feed. We also need to promote bonding. It can be a problem with the parents because of that facial deformity. So bonding can be an issue, and that can also relate to feeding and different growth and developmental delays and issues. Now, once we start having our surgeries, we need to protect that surgical area. So some places may put some sort of restraint, like an elbow restraint on the baby, so that that baby's not putting their hands up there and ruining any suture lines or anything that has occurred from surgery. We need to protect that site. Suture line care. We're just going to use like a sterile Q-tip and just kind of clean around it with sterile water. We need to be very careful we don't dislodge any of that surgical repair. Sometimes we may use like a petroleum jelly on the sutures on the outside, like on the lip, to keep it moist. Another thing we need to be aware of is these kiddos, especially when they get the palate repair, and even that lip sometimes, because if it's closer to that 6 months mark, what are we doing? We're introducing solid foods. And what are we introducing them with? At times we're using spoons. As they get closer to that year mark, they're starting to use straws and things like that. Well, those spoons and those straws could lead to dislodging of sutures or puncturing of the repaired palate and things like that. So we just need to be very careful and maybe not using spoons or straws until a certain point after the healing process has occurred. So using those softer nippled bottles and things like that. Follow-up. These kiddos, especially with the cleft palate, are going to, could end up with some speech impairments and slurring and things like that. So we may have to get speech therapy involved. If they end up having some hearing loss and some things like that, we can get ototherapy involved. With the cleft palate, we also have to watch with dental care how their teeth are coming in, because I've heard stories of those permanent teeth coming in where that new palate has been placed. So they may have to do a little bit more dental care and need braces and need orthodontic type surgeries, just to make sure that they're not damaging any of the palate repairs that have been done when they were younger. So there's just some follow-up and some longer term issues that may occur. I have nurse practitioners at the U that have had I know of cleft lip repairs because I've seen this surgical site. I know of a girl that's in her mid-20s that had cleft lip and cleft palate, and she's actually going to school to be a nurse, and she's very intelligent. Maybe if you know her and you listen closely, you would be able to hear a little bit of that slurring of her speech, but otherwise, if you didn't know her, you would never have known that she had a cleft lip and cleft palate. So some other structural defects that we may see are orthopedic related. So we could have congenital hip dysplasia or developmental dysplasia of the hip. So some characteristics is that instability of the hip. So when we're assessing that baby and their legs are pulled out straight, you will see that one leg is a little bit shorter than the other. You can also flip them over and you may see that the butt cheeks and the folds around those butts, on the one side, the folds are going to be a little bit higher than the other. Another thing that we do is when we're doing our Barlow's assessments, we're rotating the hips. And one thing we notice is we hear a click when we're doing this. And if we hear a click, that means we have a dysplasia of the hip or a hip dislocation. We should have a nice smooth movement of those hips when we're doing our assessment. The incidence of hip issues in newborns is about 10 in 1,000 births. It's more common in girls and white girls versus boys. It's more common in the left hip versus the right hip. We don't always know the clear etiology of it. There is some correlation with those breech births. So that breech presentation where that baby's coming out butt first. And so that positioning in the utero and putting a little bit more pressure on those hips coming through a canal that's not ready for it. So what's going on? So we have a subluxation of a hip. You can have complete or incomplete dislocation of that section of their hip, where that femoral head is still slightly in contact with the acetabellum, but it's not fully displaced. Now, sometimes you'll have it be fully displaced from the acetabellum. Subluxation is the most common, so you only have that partial dislocation. That is occurring. So you can have the total dislocation like I was talking about a few seconds ago, where that femoral head loses complete contact with the acetabellum as well. So how do we diagnose this? Well, like I said, when we're doing that initial assessment, we're doing these maneuvers called Ortolani's and Barlow's. Barlow's is what we're seeing in the picture, where the knees their hips are in line and their knees are bent up towards their abdomen. So that's Barlow's. And then when they start to turn out towards, like open up those legs and turn the legs out, which is on the next page, and open up the legs, that is Ortolani's. We end up seeing with this procedure the shortening of a femur with ultrasound. We can also see that asymmetrical gluteal folds in the thighs, like I mentioned earlier. So this is when we're starting to do, going from more of the Barlow's into the Ortolani's. Okay, so we've already kind of pulled those knees up more in a straight line, closed off. And now at this point, they're starting to go into that ortolani's where they're opening up the hips. Now this is more of that ortolani's process occurring where they've opened up those hips and pulled it out. And when they're doing these Barlows and the ortolani's, we're not feeling that smooth transition of the movement of the legs, and you'll sometimes feel or hear a click occurring, and that is that femoral head clicking and rotating in with that acetabellum. So ortolani's, and then we go in from Barlow's into ortolani's. So they're done congruent with each other. Okay. So here's a nice little graphic for you on just like a memorization chart on ortolani's and Barlow's maneuver, and kind of getting an idea of what we're noticing in our assessment. So how do we take care of a kiddo with hip dysplasia? They may end up with a splint. They may end up with double diapers. We don't typically do that because we want to have that hip extension. Some other things we'll do is that pelvic harness. So it's a harness that is kind of hooked around their hips, and then it has straps that are hooked onto the legs that kind of keeps it in somewhat of a flexed position, so it doesn't allow that kiddo to completely straighten out, and it doesn't allow that hip to be completely displaced. So it's kind of holding it in place, but it also allows for some movement of that baby. They will wear this continuously for about 3 to 6 months. I've seen it go longer or shorter, depending on how that kiddo's case is occurring. Another thing they sometimes do is traction, which means holding that that hip joint into place, just like any other traction. That kiddo's not able to do much movement. So they typically do traction for a short period of time, and we're going to try all these other things first. And that kind of helps reduce that dislocation that has occurred. The hip spica cast is literally they're casting the whole lower extremities of the baby in that somewhat flexed position, and they can have this cast on for several months. They will have an opening, like they'll have the groin area is open and exposed, but once again we're going to have to be doing some careful cleaning and protection of that cast and the skin around the cast. We need to make sure we're doing all that normal cast cares. Even when you're in the pelvic harness and in traction, we need to make sure we're getting good circulation to the body. So watching all that good cerebral, cardiovascular, and skin assessments and blood flow assessments, and making sure we're having good pulses and no skin breakdown. So what are we going to do as nurses? Well, I kind of mentioned a few things. Our assessment. So we need to do, if they're in a splint, we need to protect that skin under the splint. The splint is worn at all times. Making sure we're doing any exercises that they recommend. If there's a cast, and keeping that cast clean and dry. Protecting the skin around the cast. Making sure we're changing diapers frequently, and making sure that maybe even with those diapers we're putting gauze and things around the openings of where the cast starts and where the skin is at for the groin area, so that we're decreasing the contamination or the pee and poo stool from getting on the cast and on the skin as much as possible, and making sure we're good at doing good skincare. These babies, they will learn how to somewhat crawl with these casts on, literally they're going to end up with good upper body strength, and then they just kind of pull their legs around. So they do have some movement with these things. It may slow down some of those milestones, but they do learn to move around. Clubfoot is another thing that sometimes occurs. Once again, 1 in 1,000 births, boys are more common, like 2 times more likely than girls. The cause of it, we're not 100% sure. There is reason to believe that it is related to how that baby is positioned in utero. There is some genetic things that could occur. So sometimes kiddos have other genetic issues, and they also have clubfoot. It could be impaired embryonic development that led to the clubfoot. Excuse me. So what do? We do serial casting from few weeks of age sometimes on these babies. This serial casting was actually developed by Dr. Ponseti here at the University of Iowa. Dr. Ponseti, actually practiced until his late 90s, and people from all over the world would be flown into the university for these treatments. Dr. Ponseti, I think, died in the last 5 years. And we're still practicing this today, and many hospitals are doing this as well. So this serial casting, so as that kiddo's growing, they put these casts on that are holding that foot in place where it needs to go, and as that bone is forming, and the tendons and muscles are all forming, we're slowly moving it to the way it's supposed to be. Some kiddos will need some surgical fixing of the site. And that all depends on that severity and how abnormal the bones are. They sometimes will wait to start some of this until they're 4 to 9 months old. Sometimes they will start them soon, like within a few weeks after birth. But we definitely want to get this started before they're starting to crawl and starting to use those extremities for movement, because we need to get them fixed before there's more deformity or damage done. The serial casting, depending on the severity of the deformity, could last for months to, a year or so. Some of these kiddos will need some PT and OT afterwards, and some, once that casting is done, they're good to go. So in this picture, we have one foot that is clubbed and one that is not. And so this kiddo probably won't have as long of treatments, depending on how severe that one foot is. You can see it bilateral, unilateral, just like in that picture. And here's a picture of the casting. So a lot of the times it's just casting from just above the knee down. So this kiddo should be able to crawl around fairly easily because he'll be able to use his hips. We also have some other structural defects that we need to be aware of. Hypospadias, epispadias, and cryptochidism. Hypospadias occurs in 1 in about 250 males. And this is when you have the urethral opening of the penis is on the ventral, or so the lower side of the penis, so underneath. It can occur anywhere from the tip to as far back as into somewhere on the shaft. This can lead to urination problems, erection problems, infertility. Epispadias is when that urethral opening is on the dorsal side, or the upper side of the, or the top side of the penis, the tip of the penis, and that can also occur in the shaft as well. Epispadias occurs on 1 in 10,000 to 50,000 males, and these are all fairly easily fixed. A lot of the time when you have hypospadies and epispadies, they may hold off on doing a circumcision on the kiddo until they're a little bit older and do the circumcision and the urethral opening surgery, getting it back in that tip of the penis where it needs to be, all at once, instead of making that kiddo go through multiple procedures. Cryptorchidism is undistended testes. It needs to be surgically fixed. This could lead to sterilization of the kiddo, because if that testes stays up and into the body, it could cause strangulation of the tubes and everything, and also the heat can kill off the sperm. And so this is surgical repair sometimes needs to be done soon after birth, but typically they like to do it before the age of 3 at the latest. All of these are going to end up with some sort of surgery. So just normal things that we would do for surgery: protection of the site, swelling, bloody discharges, can the kid urinate afterwards, all those kind of things that are going on. There's psychological concerns with repairs. We may do it when they're older, but with some of these things, also if the child is having issues stooling or peeing, or not stooling, but urinating, that can cause some issues, body image issues as well. So I have seen the hypospadies repairs done within weeks to months of birth, after birth, just to get everything healed and ready, fixed before that child's too old, and even before the potty training starts. Infection prevention is huge. Site care is huge. If the surgery is big enough, we may have to do some catheterization post-op for a while. So we'll have to watch on that. They even talk about no tub baths until that surgical site has healed pretty well. We don't want to loosen up any sutures, things like that. Like with the hypospadies or the epispadies, if that urethra isn't long enough because of where that opening is, they may have to make a new urethra and then extend it into the tip of the penis. So, I mean, it just all depends on the severity of the defect on how much surgical repair is going to be needed. And that is the end of this lecture.